phospholipase. Yes, remember, make from inositol diphosphate what? Inositol 3-phosphate and inositol 3-phosphate, it is the secondary messenger, it open calcium channels and you have a lot of calcium. Calcium will bind with what?
Calmodulating contraction.
And okay, it activates light myosin chain kinase, and it will phosphorylate light myosin chains, and they combine with activation. Yes?
Yes.
You remember this information. What about beta-2 receptors? GS activate what?
Increase cyclic AMP.
Activate protein kinase, which will inhibit
light myosin chain kinase.
So, adrenergic drugs will relax. What about adenosine receptors? GI. And that means that if they block
Adenylate cyclic
AMP.
and increase bronchoconstriction. It is clear. Who can destroy cyclic AMP?
Phosphodiesterase.
Phosphodiesterase, yes? So, the drugs which will affect on to treat bronchial asthma, we use two groups of drugs: bronchodilators and
Anti-inflammatory.
Bronchodilators, we can speak about this picture, yes? They can affect on these receptors and something do with them. Okay, Nadia, what do you know about beta-adrenergic drugs?
Beta-adrenergic, you have selective and non-selective drugs, and non-selective acts on beta 1 and 2. So you have isoprenaline.
Will we use isoprenaline if we have selective drugs? No, because they will affect on the beta-1 receptors. Where we have beta-1?
Beta-1 blood vessels.
Vessels and no, blood vessels are
Heart, kidneys.
the main, it is the heart, yes, and kidney. Beta-1, isoprenaline, beta-1 and beta-2. Beta-2 bronchi, beta-1 heart and kidney. So they will have side effects on the heart. What about selective?
Selective, we have short-acting and long-acting drugs. Salbutamol, salmeterol. Salmeterol is long-acting, salbutamol short-acting drugs. And formoterol is long-acting, and pernodilol is short-acting.
Okay, so you need to remember short-acting drugs, and we will use them to treat acute situation, to reduce bronchospasm, and long-acting we can use to prevent bronchospasm. If we speak about formoterol, it begins to work very rapidly. So formoterol we can also use to reduce bronchospasm. So drugs to reduce bronchospasm, short-acting, and formoterol. Drugs to prevent, it is long-acting. When we use them very often and for a long time, what beta-2 receptors begin to do?
Desensitization.
Yes, they begin make involution into the cell. And we need to do something. What we need to do? How do you think? To use another drugs maybe for some time. Or to give glucocorticoids which will increase the synthesis of beta-2 receptors. Beta-2 receptors we also have on the mast cells. And they will, I will not write all, but I write about cyclic AMP. And cyclic AMP will decrease calcium in this mast cell. Do you remember about platelets? We say that in platelets, cyclic AMP will decrease calcium and prevent aggregation. The same in the mast cell. They will decrease calcium, so prevent what? Degranulation. Yes? And we can say that beta-2 agonists, they are also anti-inflammatory effects. Clear? What side effects of beta-2 receptors do you know?
Tachycardia.
Tachycardia.
Sometimes. And what?
Tremors.
And maybe some discomfort when inhaled. Okay. What about muscarinic receptors? We saw.
We have short-acting and long-acting drugs.
What we need to do with muscarinic receptors?
We have to inhibit.
To inhibit.
Short-acting drugs, we have ipratropine.
Ipratropy.
And then long-acting drug, we have acidinium and aclidinium. And then we have theotropine.
Theotropy. You need to remember ipratropy short-acting and theotropy long-acting. Theotropy, the trade name Spiriva. Right, Spiriva, because our teachers like to ask on exam. The trade name of theotropy is Spiriva. If we speak about ipratropy, it can affect on all muscarinic receptors, M1, M2, M3, yes? And it will lead to side effects. What side effects of choline blockers do you remember?
Constipation.
Constipation, dry mouth.
Dry mouth.
Yes. What about mydriasis maybe, yes? Tachycardia also maybe, yes? But theotropy, it will affect only on M3 receptors and don't lead to this side effects. Yeah. Okay. Miroshiko, what do you know about adenosine receptors? Can we block adenosine receptors?
Yes.
Yes. What drugs we can use?
Aminophylline and theophylline.
Yes, methylxanthines. We say that they are myotropic drugs. They affect on this smooth muscles, myotropic, and methylxanthines. They will block adenosine receptors, and what they can do else?
They can inhibit phosphodiesterase.
Yes, and they inhibit phosphodiesterase, and they will prevent bronchospasm. Yes, they will increase cyclic AMP and prevent the bronchospasm. What's the difference between aminophylline and theophylline?
Aminophylline is used to deny the symptoms, whereas theophylline is used to prevent.
Aminophylline is more soluble and we can give intravenously aminophylline. Theophylline we use only orally. Good. Look at this picture. Cyclic AMP will be increased when we use methylxanthines. Yes? So can we say that methylxanthines have anti-inflammatory effect? They will block phosphodiesterase and increase cyclic AMP. Cyclic AMP decrease the calcium. Yes?
Yes.
Yes. Methylxanthines also have anti-inflammatory effect. But we need to remember that they have very narrow therapeutic window, and we can't overdose these drugs because they will lead to side effects. How do you think? We have cyclic AMP in different cells in our body, or only in bronchi? Different cells. So the main side effects will be stimulating of parasympathetic system, yes, because of increased cyclic AMP, it will be some problems with gastrointestinal tract, maybe vomiting, increasing motility of gastrointestinal tract, maybe nausea, maybe tachycardia if we speak about heart, yes, maybe dizziness, and I don't like this drug. But sometimes we can use, especially when we have not bronchial asthma, COPD. So when we speak about COPD, we can use theophylline to prevent bronchospasm, because they have also anti-inflammatory effect. Okay, this is bronchiolitis. Do you have questions about bronchiolitis? Now we need to speak about anti-inflammatory drugs. Yes? Aman, what do you know about anti-inflammatory?
So there are corticosteroids mainly, and after that we have.
What they will do, corticosteroids? Do you remember where corticosteroids have receptors? On membrane
in
or
the cell
cytoplasm?
membrane.
On cell membrane, some, very little amount. But the main it is intracellular receptor. And glucocorticoid or corticosteroid will go into the cell, but with the receptor, and this complex then will go into the nucleus and activate or deactivate some genes. Yes, if we speak about inflammation, glucocorticoids will activate synthesis of anti-inflammatory substances, maybe. Yes, increase anti-inflammatory. And the main anti-inflammatory mediator is lipoprotein. Yes. What will do lipoprotein in the drug?
They inhibit the phospholipase A2
Yes, lipoprotein will inhibit phospholipase 2 and
prevent
prevent
the synthesis
of leukotrienes and also prostaglandins. Prevent synthesis of organoic acid. Yes. It will be the genomic effect. Also, they can decrease synthesis of inflammatory factors, pro-inflammatory factors. But glucocorticoids, they have some receptors on the membrane also, and they can affect on the membrane and stabilize the membrane and prevent the degranulation and prevent synthesis of different interleukins. If we speak about prostaglandins, interleukins, if we speak about allergic reactions, they will glucocorticoids decrease synthesis of different interleukins. So they have anti-inflammatory, they decrease immune system, the work of the immune system. They prevent synthesis of lymphocytes. Bronchodilation, they don't get. Yes, they can increase synthesis of beta-2 receptors. Yes? And we usually combine glucocorticoids and beta-2 agonists to treat the patient. So, genomic effect, it is when they go into the cell. Non-genomic effect, when they have effect on the membrane receptors. Yeah. What side? Let's speak about the drugs. How do you think? How we need to use these drugs? Inhalation. But we can use also systemic. If we speak about inhalation drugs, what drugs we need to name? Budesonide, fluticasone. Okay. Systemic. Prednisolone. Good. The side effects, when we use them oral or by inhalation, they decrease the immune system in our mouth, and it may lead to what? Infection and candidiasis. Usually it will be. They can also have effect on our voice, croaks, yes, croaks, and lead to dysphonia. And patients will speak very special voice it will have. But if we speak about systemic effect, what side effects may be? The patient will have very fat face, very large abdomen, and very fat neck, yes? But very thick legs and arms. Why? Because muscles will be destroyed, proteins will be destroyed. What else? It can increase glucose, yes? It can increase blood pressure, destroy bones, lead to osteoporosis. When we will use for a long time, it may lead to cortex insufficiency. Yes? When we will stop, if we use for a long time and large doses, when we will stop using these drugs, it will lead to withdrawal effect. Do you have questions about glucocorticoids? No. It is the third group of anti-inflammatory drugs. What about second group, Vinajah?
Second, we have leukotriene inhibitors. So it can be divided like one which inhibit the leukotrienes binding to receptors of smooth muscle. So it is montelukast and zafirlukast. And we also have like zilucine inhibit the lipoxygenase.
So, the second group inhibit lipoxygenase ziluton or inhibit the receptors montelukast and zafirlukast.
They can cause hepatotoxicity like zilucine.
Yes, for a long time. If you will use, they can lead to this. In our country, we don't have ziluton. Maybe in the USA, patient can use this drug. I don't know about your country. Montelukast we use widely in our country, and not zafirlukast, montelukast. Next group of the drugs. How do you think? Can we affect on the
Yes. Yes.
what drug?
Omalizumab, monoclonal antibody against IgE.
You know this drug. We also have another drugs which can monoclonal antibodies which can block interleukins. But you don't need to remember because you don't have in your protocol recommendations. If you remember dupilumab, benralizumab, mepolizumab, you can say about this. Do you have in your book these drugs? No. Also, don't say about them. What about mast cell? Can we affect on the mast
Master stabilizers.
stabilizers? So they will decrease calcium in the mast cell and prevent degradation. What drugs?
Chromolytic acid.
What's the specific features of these drugs? We need to inhalate chromoglykans or chromoxid 4 times a day and during a month to have effect. How do you think? Will patient inhalate during a month 4 times a day to have effect through the month? If they have very effective drugs. No, nowadays hormones it is not so widely spread, but you need to know that these drugs we have. Sometimes we assign to small children, yes, to children, or when patients have bronchial asthma associated with physical exercises. And what about ketotifen? Do you have ketotifen in your book? It is also stabilize mast cells, but it has also antihistamine effect. Blocks histamine receptors, yes, and may lead to sedation. Antihistamine effect. Some people say that it is antihistamine drugs, but it is, I think that it is stabilizer of mast cell membrane, ketotifen. And the effect we will see only on the fixed day when we use it. Do you have questions about this part of our classes? No. Okay. What? We need to repeat. Okay. Where is Zainab?
Zero is absent.
Will not come. Okay, Sadhan. What do you know about broncholytics?
Broncholytics, we basically use the drugs to increase the bronchodilation. So there are 4 types of receptors present in the bronchial membrane. We have leukotriene receptors, muscarinic 3 receptors, and beta 2 receptors and adenosine receptors. And beta 2 receptors, they usually cause bronchodilation because they are coupled with GS protein, and it will lead to the increase of adenosine cyclase and will produce AMP and lead to production of protein kinase, which will inhibit light myosin chain kinase. So when we are using drugs, we have to use beta 2 adrenergic agonist, which has a similar structure, so that it will activate the receptor and cause bronchodilation. When speaking about muscarinic receptors, it causes bronchoconstrictions. So we have to use antagonist to muscarinic receptors. Examples for muscarinic receptors, you could use ipratropium and tiotropium, and for beta 2 agonist, you could use salmeterol, salbutamol. Salmeterol is long acting, salbutamol is short acting. And we also have adenosine receptors. Adenosine receptors are linked with the GI protein, and GI protein inhibits adenylate cyclase, so it will lead to bronchoconstriction. So we have to use a drug that will inhibit adenosine receptors. For example, we use methylxanthine drugs. And you also have leukotriene receptors. Leukotriene
receptors, we don't speak that they are broncholytics. They anti-inflammatory drugs. Okay, Nushka. What about anti-inflammatory drugs?
So anti-inflammatory drugs, we have corticosteroids. So corticosteroids, they bind to glucocorticoid receptors in the cell membrane, and they will translocate into the nucleus, and they can decrease.
If they bind on the cell membrane, they don't have anti-stabilizing membrane. But if we speak about genomic effect, they will go into the cell and bind with the receptors into the.
And they can produce anti-inflammatory genes. The main anti-inflammatory gene is lipocartine that will block phospholipase A2, so it will produce leukotrienes, blocking lipoxygenase. So it can also decrease the production of inflammatory genes like COX.
If we will block COX, we will prevent synthesis of prostaglandins, or they can decrease synthesis of interleukins. Different. What drugs do you know? Glucocorticoids.
So glucocorticoids, they can be inhaled, they can be oral agents. So if they are inhaled, they can be, if they are oral agents, it can be prednisone, and inhaled agents are fluticasone, budesonide, and beclomethasone. Inhaled agents, they have side effects, they can cause
and dysphonia. And you will speak about systemic side effects.
Systemic side effects are like increase of blood pressure, increased glucose, and cortex deficiency.
And destroying of protein, insulin. Okay. What about another group? Anti-inflammatory drugs.
So there are leukotriene blockers.
Name the drugs. Okay. What about lipoxygenase? Can we block lipoxygenase? Yes. And the name of the drug? Zeleoton. Okay. Can we stabilize the membrane of the mast cell, and what drugs?
It is
Chromos. You can say chromos. It's a group of the drugs, nidochromyl and chromoglicate. It is chromos. And what about immunoglobulin E?
They are anti-immunoglobulin E drugs. They will prevent the binding of mast cells, so therefore it decreases the sensitization of mast cells for immunoglobulin.
And the name of the drug? Omalizumab, monoclonal antibody. Okay. Now I will give you the task to discuss the next part of our topic.